with this test and you really got down to business, and today's your reward. You pass. So I mean, it's that's rewarding, right? I think that's one of the best feelings ever, if you ask me, is passing the board and be done with that. If you think about everything you do before this moment is because somebody's expecting of you. If you don't do this, you don't graduate. Now you graduate and no one is expecting you to do anything else. It's like you paying yourself now for all this time and the work that you have done in the past few years. It comes down to this test. So congratulations. That's super exciting. You know?
Yeah, I just wanted to tell you, I listened to one of your live reviews that was recorded. I think it was module 2, part 1 video. And I just found it very motivating. So it's like what I needed just to give me that boost of confidence. So thank you very much.
Well, congrats. Now you go on to bigger and better things. So you did super well, Erika. Congrats. Thanks for the shout out for the others, motivating others here today. So congratulations.
Thank you all. You all could do it. Thank you.
Absolutely. All right, folks. Let's see here real quick before we get started. Who got questions? For some reason, June.
Hello, Lopes. I don't see my name on the list. Could you please bring your list up and see if I'm here?
Right. So if you already joined the game, you are here. It's because others have joined after you. So your name probably went down. June, I see your name.
Oh, you see my name? Okay,
no,
thank you.
it was Angel. No, it's okay. No, I don't know what name you picked. How would I see your name?
Oh my God, I shouldn't let you trick me like that. You don't know.
Are you the hippocampus? No.
I'm Lily.
All right, Lily. Okay, let's look.
Oh yeah, I see my name. Okay, thank you. Dr.
Okay.
Lopes, you haven't sent my email yet.
Oh, because I have so many emails to answer, but I'll be getting back to you.
Right.
Okay.
Thank you so much.
All right. Alrighty. Last folks here, then we get started. Okay. Fumilola.
Yes, Dr. Lopes. Real quick, I just subscribed to your to all the materials just last week, and I just completed those 5 PDFs. So which should I go to next? Should I start doing the Qbank or go do something else that says day 1, day 2, day 3, day 4, day 5? Which one should I go on to now?
Okay, please send me an email. I'm gonna write it down for you step by step. So, okay. But in summary, you go to the video lectures. You complete 1 module per week, complete module 1 this week, and then you go back to the question bank, and then you complete question bank 1. Go back to the video, and you complete video module 2, and you go back to the question bank, and you do question bank number 2. While all that is happening, you still come to the live class, so we can discuss things and cover 1 module as well live. So you are doing a hybrid kind of setup, doing the videos and come to the live class. And there is no rush. There is no rush. You don't have to finish this in 30 days. It's only realistic for few people. Like Mrs. Cano, she did in 2 weeks. I don't know how she did so fast. But, you know, most folks need a good 8 weeks. But remember, once you are enrolled, there is no charge. I'm not telling you that you need 8 weeks because, you know, I'm gonna charge you monthly. We don't charge anybody monthly, okay? So at this point, all what we care is that you take your time, understand it, and go test it. That's simple as that.
So this is not for me right now. This this session here right now is not for me.
It is. It is. It is for you because you are going to see some stuff that we covered on module 1 yesterday, right? You are going to see a very high yield points. You are going to see things that really matter for the board. Anyone can create a course and throw it at you of, you know, 10,000 page books and say, go read it, right? But we're trying to really condense it to what's really important. You know, what is going to kill your patient, basically, right? If you worked at ICU, ER, I can totally miss something simple, but I cannot afford to miss a heart attack or inflamed appendix or something that can be very dangerous, right? So this is what we're doing in psychiatry. What are the things that are very important and that I know if I had written the test, these are things that I would ask. So that's how we're managing this course, okay?
All right, thank you. All right.
All right, folks, at this time, we're about to get started, okay? So let's explain how you play on the phone. Obviously, my kids stole my phone, so I don't have a phone. This is AC. Let's pretend this is the phone. Once the game begins, you will see 4 options on your screen, on your phone. You are going to enter or press on your phone. Kahoot is a game of purpose and speed. What really matters is you get the question right. You only have 1 minute. The questions are usually simplified and the answers are even more simplified. Kahoot only allows me to have few characters per answer, so it's not standardized like the board, right? So be mindful of that. There will be lots of abbreviations, but do your best. The purpose is find the answer, get off the fence, select your answer. You get more points for being fast and obviously being correct. If you're incorrect, you get 0 points. Okay? So let the game begin. Okay, good luck, everyone. Kahoot is extremely difficult to make the podium. Very hard. There will be maybe 100 people playing tonight, right? So it's very hard to make the podium. Your job is to always want to make the podium, okay? At minimum. All right, so the game is about to start now. Good luck. Make sure you enter. Make sure you enter the answer on your phone, not on this meeting, okay? All right, let's do this. 1, 2, and 3. All right, smile, the last one. Daddy. Bye, everyone. Now let's do it. Now it begins. All right, 10 seconds. All right, so the core of the question is heightened anxiety and low mood, right? We can boil down to low mood and hyper anxiety. Which one of those causes low mood, right? I mean, a lot of things can cause low mood, right? But primarily, if we were to pick one, it would have been serotonin. Now, if one is too hyped up, then blood pressure goes up, anxiety goes up, which neurotransmitter is most likely associated with norepinephrine, right? So overwhelmed. You don't seem overwhelmed. You're in the first place, fast and furious. Okay, so I just want to kind of like review a little bit from yesterday real quick. Where those neurotransmitters are made, produced, or synthesized, right? Same thing. When we talk about norepinephrine, the lucus coeruleus and the medullary reticular formation. So what is really important for the board, highly implicated in fight or flight, being anxious, right? If the right dose give you purpose, focus, and alertness, too much of it gives you anxiety. Now, oftentimes the board may ask you one neurotransmitter most likely associated with nightmare, right? Then you know it is norepinephrine. No wonder what medication we use to cut norepinephrine down and decrease nightmare. Prazosin, right? If you have too much norepinephrine, you are more likely to have insomnia or even hyperarousal state. Serotonin, all about the mood. Raphael nuclei. Remember, if you're looking for Raphael nuclei as the answer, you don't see it. Look what is above. In this case, where's the Raphael nuclei is at the brainstem. It's all about mood, sleep, appetite, pain perception, guilt, right? Feeling guilt and impulse threshold. The clue here for the exam, sometimes we may give full dose of Zoloft, right? And then you wonder, why is this patient not getting better? Sometimes it could be a deficiency in the receptor. Maybe you need to target another type of 5-HT, for example, such as 2C, which may be a little bit more advanced than what we teach on the board, right? Those are directly linked to clinical depression, anxiety, and obsessive compulsive disorder. So if you ever find a question on the board in which the patient has tried Zoloft and it didn't work, it went enough time, right? Let's say in this case, 12 weeks and that full dose, it doesn't work, try another receptor of serotonin or try a atypical antidepressant, such as mirtazapine, maybe Wellbutrin, right? Target a different receptor. Dopamine. Dopamine, it's all about pleasure and reward, right? So the nucleus accumbens is the reward pathways. The VTA, to help you remember, very tired addict for its roles in addiction, the ventral tegmental area, and the substantial nigra, which is super high yield because it's all about movement. Board track. Think of GABA and dope. Gabapentin, not gabapentin, but GABA and dope to help you remember the two neurotransmitters often tested for substance use disorder. Exam clue. So when we talk about the dopamine pathways, right, it's really talking about the D2 receptor blockade or low amounts of dopamine. If you have a low amount of dopamines in the substantial niger, right, it is directly correlated to increase in EPS. Low dopamine leads to high acetylcholine, which leads to extrapyramidal side effects. Acetylcholine is synthesized at the nucleus of Neymert, right? So what I would call board track here is essential for memory. It's all about memory, cognitive processing, attention, and also plays a role in sleep awake cycles. If you think of a cholinesterase inhibitors or such as Benadryl, right, or anticholinesterase, antihistaminergic medications, put you to sleep, right, like Benadryl. If you have too much of acetylcholine, it really keeps you up as well. Now, the board clue here, it plays a significantly decrease in dementia. So if you ever ask what is one of the issues with dementia, it's all about memory, right? So acetylcholine is often low in dementia patient, Alzheimer's patient. That is something important to understand, that Alzheimer's, think of low memory. That is something that is often tested. Okay. So if you, no wonder, what do they get for dementia medication? The core of dementia medication are cholinesterase inhibitors, right? Like donepezil are used to block its breakdown and preserve cognitive function. Okay, so hopefully those four neurotransmitters kind of helps you kind of like at least know where they are made and how important they are in psychiatry. All right, kind of tricky question, right? Because the green is actually true, right? But how does alcohol and lithium truly interact, right? We all know that it should be avoided, right? I hope you never say, well, go home and drink 2 bottles of wine with your lithium, right? So think of the consequences of lithium and alcohol. How does it interact? Lithium, it is super high yield for this keyword, which is reduce renal rate, right? So it does, if you have to compete with dehydration, it will cause lithium to even go higher, right? So have alcohol usage often causes systemic dehydration. Now you have to deal with maybe even the body trying to compensate by keeping sodium, but it kind of mistakes sodium with lithium, which is also is a salt. Now things go from bad to worse, right? So now the medication that often is tested is Zoloft and alcohol, right? And even though SSRIs are the safest in case of overdose, excessive drinking and excessive consumption of SSRIs can be fatal, right? Excessive. Now, your patient is not going to die usually, usually if you have a glass of wine every now and then, should not be a huge problem, but don't suggest that they do it anyways, right? You want to keep your license. But if it's too much of anything, even too much of a water can be harmful, right? So excessive usage of alcohol with any medication can be very dangerous. So I just want to kind of touch base a little bit on on lithium, right? So it's, if not 100%, is really near 100% excreted by the kidney. So very, very, very little, it's not even significant, excreted by the liver at all. So think of lithium, renal. Anything that's going to compete or affect the renal filtration rate will likely cause problems with lithium, right? Dehydration, it is a high yield point for the board and it's often tested on patient teaching. think about what would you say to your patient, right, if they are taking lithium? And obviously, low sodium. That should be no surprise, right? Hyponatremia will cause lithium to go up, right? So keeping a good hydration. And in regards to sodium, they need to keep a steady state. What I mean is do not avoid, do not go over. Just a steady normal consumption, right? Trying to keep the sodium at healthy levels. So yesterday we talked about the happy house. As I mentioned, for lithium here, we want to be on this very narrow window, 0.6 to 1.2. Now there is this gray area, 1.3 and 1.4. And that is precisely what the board loves to ask you, because everybody knows if reaches 1.5, it is toxicity. So they are going to target things that is not often talked about it, right? But can be reality. So what happens if your patient is 1.2, 1.3 or 1.4? If the patient has symptoms, you should stop. No symptom, assess, and continue the medication. Okay? What else is important? Toxicity versus side effect, expected side effects. So yesterday we discussed about fine hand tremors is expected, right? Maybe a little bit of a polyuria, polydipsia to some level accepted. Maybe a little bit of a hypothyroidism expected, right? White blood count, leukocytosis will be slightly elevated, and they may have moderate weight gain, right? So what we need to work on is patient education, okay? Now, anytime we see toxicity levels, we never collect lab and stop the medication. We stop the medication first and then collect labs. Few of the things that are often shows up on the board: coarse hand tremor, slurred speech, confusion. Anytime you see severe or continuous or projectile vomiting, that is not normal for any medication side effect. Otherwise, it would never be FDA approved. Right? They may have ataxia, wobbling gait, right? Now, think about lithium interactions. I think I mentioned this 20 times yesterday. NSAIDs. Now, they may never say NSAIDs. They may say lithium plus naproxen, especially most high yield indocin, right? So, or ibuprofen. Now, thiazide is also high yield, and lisinopril, right? Lisinopril is super high yield. Just remember, lisinopril, ACE inhibitors are also used for heart failures and ARBs, right? So all those medications are also metabolized or filtrated or excreted by the kidney, right? So they are competing with lithium and could possibly increase lithium levels. All right, 10 seconds. All right, great. So I'm glad that almost 100%, and I'm sure that the person that picked the green answer probably selected the wrong answer on the phone. Totally get it. Sometimes it happens. Determined. She is the first place. KB, Mango, Steven, Pixel. All right. So you guys are, you saw that 73 people got the first question, the second question correct, right? So they're on a strike, but they still did not make the first place. So you have to be fast. So yeah, so excessive thirst, polydipsia, and increased urination, or more than expected polyuria, can be indicative of first stage of lithium toxicity. But in itself, only those two side effects or expected side effects are not necessarily a reason to completely stop the medication. So in that case, you want to be reasonable, collect labs, and then you make your right judgment, right? Next question. All right, so super happy. Most of us kind of got this one correct, right? So we have to be very, very mindful. This is, I think, probably the most high yield, or would say the top 5 that will be on your board. Interaction with clozapine and olanzapine, right? These are the heaviest second generation antipsychotics. Remember that first generation gives you more EPS. Second generation doesn't have as much EPS symptoms, but unfortunately has metabolic syndrome, right? So patients on olanzapine, clozapine, or even quitapine, right? They can develop weight gain. You want always provide an alternative. Obviously, the first thing you do is provide lifestyle modification. If that doesn't work, then we can do Abilify, we can do Geodon, we can do Latura, and there are many others, but those 3 are the most tested for the board, right? So if we think of metabolic syndrome, what is that to begin with, right? So think of one that's the highest weight gain would be clozaril, followed by olanzapine. No wonder clozaril is an excellent drug, but it carries a risk for agranulocytosis. And obviously, because of the metabolic syndrome, we don't use it as much. But in practice, and let me tell you a secret, if your patient is developing EPS early, I like to change them to olanzapine. I'm sorry, clozaril, right? It does well for TD until you have to do another measure. Okay, it can be helpful for that. So we talked about alternatives, the Zal, ziprasidone, Abilify, Latura, and think of the first physical signs for metabolic syndrome, right? Increase in waist circumference. Okay, what else we can talk about here? So because any time, this is real psychiatry, not just for the board. Very important. If you are considering prescribing any antipsychotics, you need to do your labs first. So obviously measurements like BMI, height, weight, hip to waist to hip ratio, which is the same thing as the waist circumference. You want to get the good measurement of glucose, not just your blood sugar for today. You want to look at A1C, that shows you for the past few months how the glucose level is doing for the patient, right? And you want to definitely get lipid panels. Yesterday we talked about how olanzapine can really be detrimental for some patients and can boost up the lithium lipid levels, right? What else? We also talked about non-pharmacological measures in psychiatry in general for all medications. If you can do something, or if the patient can do something for themselves that doesn't involve change the medication, that is always a good trial. It doesn't mean it will work, but it is an alternative that we can help and facilitate, especially if they are stable. CYP 182, remember, it's not only olanzapine and clozapine. Think of duloxetine. It's also high yield, but not talked about very often. And now think about how either one of those medications interactions with CYP 182, if they are smoking currently, you need to increase the dose. If the patient scenario says he was smoking, then decided to stop smoking, then you need to decrease the dose. These are super high yield points, okay? All right, great question. All right, so is weight gain and thirsty or polydipsia or are those things expected with lithium therapy? Yes, right? So if they are expected, what should we do first? Okay, yes, order thyroid function, sure. That is a good answer, okay? But is polydipsia or polyuria a side effect that you would expect with hypothyroidism, right? So that is the question. So we want to, since those side effects are somewhat expected, we should provide education about the possible side effects and how to manage those side effects, right? So these are they're expected non-toxic or toxicity levels, right? So they're well expected, well within the range for providing education and finding countermeasures, especially if they are stable. They are stable on lithium. You do not want to abruptly stop or switch to another mood stabilizer, right? For those benign expected side effects. So you want to provide education, offer them the opportunity to have informed decision of what they want to do. Okay, so why ordering thyroid function is actually a strong, you're not wrong, is a strong second option here, right? So again, lithium can cause hypothyroidism, right? Weight gain, ordering labs, tests, diagnostics, intervention. The question asks for the overall best approach to address her generalized somatic concerns. How is that ordering? So this is a perfect example of how you found the solution for general when someone is taking lithium or another medication, but it's the wrong choice. Ask yourself, how is it going, how ordering labs is going to address her concern? Hopefully that makes sense, because it's not wrong to get a thyroid function test. It is what we should do, but it is not addressing the core of the question. What is the core of the question? You know, she's concerned about the side effects, right? So providing education would address the core of the question. So I love this question because kind of guide you to take to order a thyroid function test. But if you, every answer that you select, ask yourself this: how is it going to address the core of the question? If it doesn't, it cannot be the answer. Okay, it is simple as that. But we see this lab, it'll be like, yeah, it fits because hypothyroidism, but it's not addressing the core of the question. Okay. All right, 5 seconds. 2 and 1. Okay, great. So a strong distractor here is green, the green option, right? Dehydration may lead to toxicity by reducing GI absorption, right? In itself is not a misleading statement per se, at least not, because if you are dehydrated, your stomach is not going to perform as well either, right? But the core here is that dehydration causes lithium levels to rise. And how does it do is by trying to retain water and now try to retain sodium, right? Because water follows sodium, and by mistakes picks up more lithium, and now it becomes this snowball of problems, right? So yes, the dehydrations with patients, when patients are dehydrated, intravascular volume drops. In response, the kidney says, oh no, I am in trouble, let's conserve water. And when it does, it mistakes, right? Let's conserve sodium and water. When it does, it mistakes lithium, which is a type of salt, and instead sodium goes down, keeps lithium, and now we have a big problem. Okay, so
Dr. Lopes, can I ask one question, please? I'm sorry to interrupt.
Go ahead.
Yeah, so my screen is showing number 16 question. Have you gotten to 16 question? I don't know how mine is jumping.
Because some of the slides are not questions, some of the slides are teaching points.
Oh, okay. Thank you.
No problem. You know, it's all good. I was watching soccer game with my mother-in-law, and she's a little bit older. And every night she asks me this question: "The game just started. How come it's in the second half?" I was like, "You slept." No, it's because it was recorded, the best moments, you know. So similar situation here. Every night, so we did the same thing. Bless her heart, I guess. Or me, I guess, being mean to her. Anyways. Okay, so we all been med surg nurses at one point in our life. So some of us still is, right? I guess once you've been, you never let it not be, never let out of you. But think about peaks and trough when we did vancomycin, how important that is, right? So if you want a correct measurement, you have to at least provide the patient some guidance, right? Whether make it consistent at least, so that way the results are not misleading. What if the patient just took lithium and then an hour later gave blood? That could be, might be like, whoa, this is too high. That could be misleading, right? Especially if it was borderline and now the patient took another dose, it could be misleading. So the best practice at minimum, keeping constant, always the same time or nearly the same time. It doesn't have to be 8 o'clock in the morning, right? But keeping constant so that the results are not influenced by the when the patient took the last dose. I see lots of hearts here. I don't know what is going on. Must be good news. All right, this type of question is super high yield, and I'm super happy that 157 of you guys selected the right answer, right? So I have no doubts this type of questions will be on your board because it's all about patient education and one of the most dangerous education because of the narrow therapeutic window, right? So dehydration and lithium can be dangerous, and we don't want to overshoot for lithium, right? So we talked about the interactions of dehydration, sodium, and so forth in regards to lithium. So just leave it at that. All right, so lithium neuroprotective choice for those patients with bipolar, right? But also some studies has been suggesting lately that it does improve cognitive function in elderly and specifically with those with bipolar disorder. Now, it's not necessarily like other medications that may boost cognition significantly, but it does has it has shown to modestly, or at least it doesn't decline. It contributes a little bit with cognitive uh, performance to some levels, so it does preserve uh, some good cognitive function, right? So keep that in mind. All right, so let's start with the gray, right? Is lithium well known to cause hypertensive crisis? What medication is known to cause hypertensive crisis?
MOAIs.
That's it, right? Now let's go to the next critical question. To some level, is benzos going to drop your blood pressure significantly? Now, like not to the extent of someone is on 200. It may drop a little bit, right? It's going to relax, it's going to decrease norepinephrine, but it's not going to do a dent for someone that's critically going to the ICU at that point, right? But you will get admitted, and I have never seen benzodiazepine being given for that. Even if it's given for the anxiety, it's still not addressing the main problem. So now we have two other options. We have the red and the green. Do I really care about anything else at this point other than preventing my patients from having a stroke? No, I really don't. Now let's put it at the different perspective. What if the mood stabilizer is a inhibitor, right? It doesn't mean because you stop giving MAOIs, the MAOIs is gone, right, out of the body. It's going to take about 2 weeks for it completely clear up, right? By having an inhibitor, it's it's still going to keep it the remaining MAOIs. So what is the safest option? Stop everything, address the high blood pressure, extremely high blood pressure. Not I mean, yes, by any book means that would be extremely high, right? Patients are going through hypertensive crisis, so we need to admit this patient. That's the first and most important thing, and then we need to do some very fast measures, right? So we definitely need to discontinue all medications at this point, right? And we can address anything else after, but hypertensive crisis is not something that we want to deal with, right? Usually is an admission to the hospital. So one way to think of a hypertensive crisis, think of PATS, pressure, to help you remember, of the tyramine, hypertensive crisis, and tyramine, agitation, tremors, and obviously sexual dysfunction for MAOIs, right? So when we talk about the three high yield crises from yesterday's content or from module one content is hypertensive crisis linked to tyramine, and we want to avoid any medication that could boost tyramine or blood pressure, i.e. stimulants. We don't want to give a stimulant to a patient that's already taking a MAOI reasonably, right? Unless if we are measuring the blood pressure monthly or so forth, right? And we talked about what medication we want to give an alpha blocker, pentolamine. It is high yield. I would memorize this medication. And then we talked about serotonin syndrome and NMS in super excruciating detail. And I ask you guys never to confuse ciproheptadine with bromocriptine and dantrolene. More so, we discuss how you need to know that bromocriptine is a dopamine agonistic because what caused the problem was a neuroleptic malignant syndrome, was a antipsychotics, right? So we did to blockade or antagonistic, and we want to give a dopamine agonistic, okay? And dantrolene for examples of muscle relaxant. The question will tell you, for this patient, you want to select a D2 agonistic, then you pick bromocriptine. If the question asks you to select to help the patient relieve the muscle tension or the lead pipe rigidity, then dantrolene. Okay, very high yield. Guarantee you will see those three conditions because they're emergency. Why would you not see? Think about it. We are not. It's only 175 questions in all psychiatry topics. What are the things that could kill the patient that is super important for you to know before you start your practice? Everything else, the details, we can learn as we go, but we cannot afford not to recognize hypertensive crisis and MAOIs. We cannot afford not to recognize serotonin syndrome or neuroleptic malignant syndrome, the things that are going to kill, right, the patient. Could kill the patient at least. All right. So why we do not want someone thinking about become pregnant on lithium, right? And is lithium the only mood stabilizer that I should be concerned about? No, right? So lithium is super high yield for those planning to become pregnant, or if they are pregnant, we want to switch them right away, right? So it can cause birth defect. Again, we are talking about things that can be very dangerous to the mother or to the fetus, right? And can cause abstinence anomaly. And I kind of emphasize it way too many times yesterday that they will never ask you the question. It's always a patient scenario, right? How do you recognize what abstinence anomaly is? A murmur, you auscultate a murmur, and then you kind of like um, ask the patient, maybe was your mother taking lithium while pregnant with you? So you're connecting really the dots of memorization and application. So if you think about board strategy, you definitely want to taper, right? But someone that isn't in real life, you want to really as fast as possible. You don't want to do a slow taper, but you want to switch them to something that is less harmful, or at least in theory. And when we think about in theory, what could be less harmful for someone that is pregnant or planning to be pregnant? Lamotrigine usually is your go-to medication. Now, remember, lamotrigine can cause Steven-Johnson syndrome, so therefore you start slow, very slow, right? Very slow. Start low and go slow, right? Now, is valproic acid any better? No, definitely not. Neurotube defect or spina bifida for valproic acid. How about carbamazepine? Is that better? Definitely not. Contraindicated in many levels, right? So it can cause congenital malformation and neurotube defect. So in summary, planning to be pregnant, it is currently pregnant, switch them to lamotrigine, okay? You wanted to provide education on that heavily. All right. So, is the patient taking a antipsychotic? No. Cross the yellow option. Is the patient taking a antipsychotic? No. Cross EPS. You don't get EPS for mood stabilizer. Is the patient taking lithium? No. The scenario was Depakote, right? So process of elimination. We only have one possible choice, and we're talking about hepatotoxicity, right? So, folks, even if we don't know the question, this was a given. Even if we didn't know about hyperammonia level, this was a given from the knowledge that we learned from other content. Okay, so sometimes we have to really think through what are we selecting, and are we automatically pick something, or are we thinking through the question? Okay, because definitely was not about lithium. This was straight up Depakote, and it was not about antipsychotics either, right? So now let's talk about the two FDA warnings. What do they look like, and how the questions will be asked? It's all about patient presentation, and we also need to discuss some of the labs that we'll collect, right? Because after all, they are FDA warnings for a reason. So in general, when we look at valproic acid, we're looking at 50 to 125. It's the good place to be. If it crosses the 150, dangers, right? In general, for all mood, I'm going to say all mood stabilizer or antipsychotics, or even any patient in psychiatry, even if the medication is not well known to cause birth defect, we always want to at least consider HCG. right? And when we say to who are the patient population, anywhere between 12 to 50 years old females, right? In general. Now, we can go from very mild, like SSRIs, Zoloft, to extremely dangerous, like the medications that we discussed earlier. Now, the two FDA warnings for Depakote that you must fully understand will be on your board. Hepatotoxicity. Now, they will never ask you that question. You know, what are the two FDA warnings for Depakote? What they will ask you is, in fact, they will not ask you that. They will give you a scenario, right? They'll give you a scenario. They may have a brownish color urine with abdominal pain and malaise, right? So that's really telling you the liver is affected. And then the first thing we want to do is get LFTs. And because hepatotoxicity is associated with high ammonia level, right? We want to get ammonia as well, okay? So if the patient shows new onset of disorientation, it's really screaming, ammonia level, lethargic, or increased hand tremors, you want to really rule out valproic acid induced hyperammonia levels. Okay, so what else we would be concerned with Depakote? Pancreatitis, infection or inflammation of the pancreas, right? Is that emergency? Yes. And so is hepatotoxicity. So for pancreatitis, what are the things presentation like? Usually upper quadrant abdominal pain, right? And they may have this pain radiating to the back that is super high yield. So in nursing school, what did we see probably in NCLEX? Oily, foul smelling stew, right? We definitely saw that in the NCLEX. I remember 20 plus years. It was there, I promise you, right? So what else? They because it's an infection, inflammation, not infection, inflammation of the pancreas, the body's going to react. So we are going to have tachycardia, most likely a high fever. That is an emergency scenario. So if you ever get a call and they present that way, don't come to my office, please. Go to the AD. I don't want. I'll shut the door. I don't want to see you. Okay, you got to run to the office. What kind of labs we would select for pancreatitis? Amylase and lipase, right? And because we definitely want to get the CBC and the CMP, right? So just remember, they will never ask you those questions, but you need to identify the scenario by knowing what is hepatotoxicity, how is it presented, and how pancreatitis is presented. And the answer, what they really care is not how is it presented, but is what is your action, and boils down to the last sentence here. Don't come to my office, please go to the AD, right? I mean, I'm exaggerating, but this is emergency, okay? Address such as one. Go to the emergency room, get treated now, not tomorrow, today, immediately. Okay, so that is very important. So we kind of boil down what is really important about Depakote. There are a few other details that are less tested, but these things that we went over, the patient presentation, our action, the labs to collect, and obviously, previously we talked about possible birth defect. These are high yield points. Now, if we think about HCG, that is a good question to be asked about HCG. And so is someone presented to the AD, maybe talking fast, female that screams first, get HCG, do everything else after. Okay? You don't want to get sued and say, it was because of you. All right, 7 seconds. All right, so here, we talked about advise the patient to continue lamotrigine, right? Benign rash, or rash that goes away, it is not necessarily Stevens-Johnson syndrome. Now, Stevens-Johnson syndrome sometimes may not present with rash. They may just present with the fever. Stop the medication. Patient on lamotrigine and fever, stop the medication. How about lamotrigine and anginal edema, swelling of the tongue? Stop the medication with rash or no rash. And I know 100% of you guys will stop the medication if it's severe rash, right? So remember those points. They are less talked about, but extremely high yield for your board because everyone can recognize Stevens-Johnson syndrome. What about if it's a benign rash? What if it's swelling of the tongue? You know, they are looking for gray areas, and our job is to look for those gray areas that are not talked about on books, right? Books don't necessarily goes in detail and repeat several times when you should stop lamotrigine. Okay, we do. Wow, 100 answers in less than 15 seconds. That must be an easy question. You guys really want to make the podium, huh? All right, 5 seconds. Okay. How is how is collecting CBC is going to address severe abdominal pain? Again, it goes back to the previous question. This was more telling, right? It's not going to address the problem. If you're selecting an answer because it makes sense but does not address the problem, it's most likely the incorrect answer. I hope you don't continue Depakote, right? I think that's a mistake. I'll cross that out. And you don't want to prescribe antacid and hope for the best, right? So we are describing pancreatitis, right? So hopefully I was hoping that we would get 100%, but sometimes I do get it at Kahoot. We're playing on our phones and we can just try to do it fast and it happens, right? But remember, black box warnings for all medications that are important will be tested. So that could easily give you another 10 points just by knowing that. All black box warnings will be tested. Tell me one medication in psychiatry that has a black box warning and that is not tested. Probably none, right? We can go SSRIs, we can go lamotrigine, we can go Depakote, we can go lithium, we can go antipsychotics. All black box warning will be tested. And this is one that's very obvious that will be on your test. And in the previous slides, we talked a little bit more in detail of hepatotoxicity, what it looks like, and the labs to collect, and pancreatitis. Okay. So on the previous slide, I mentioned that all black box warnings will be tested. So what are the black box warning for carbamazepine and, well, in this case, carbamazepine, agranulocytosis, right? And the plastic anemia. So if agranulocytosis is a black box warning and I am concerned, then what should I do in any signs of infection? There is only one action, is to stop the medication, right? I see how giving antibiotics could be helpful, but it is not necessarily what I'm concerned. I'm concerned about the white blood counts to drop and my patient dying of no body immune defense, right? Because if it gets, the white blood counts gets to be dangerously dangerously low, then it's going to be a bad day. Okay. So remember agranulocytosis and chlorophyll, right? Both. 1 second. Folks, watch your mics kindly, please. So remember, chlorophyll and carbamazepine both could lead to agranulocytosis. So any signs of infection at all or sore throat, stop the medication. Chills, stop the medication. What if ANC is 2000? Stop the medication. Any signs of infection, if they dream of they're in Alaska and they're having chills, stop the medication. I'm telling you, okay? And I promise you, questions will make it sound it's no big deal. It's just a sore throat. White blood count 5,000. ANC 2,500. Patient is laughing and watching TV, but ask for for something for his throat because it's itching. Which of the following should you do, right? It doesn't seem serious at all, right? It doesn't at all. But I'm telling you right now, any type of anything that suggests that could lead to an infection or there is an infection brewing, your action should stop the medication immediately. Not collect labs first. Stop the medication. Can we get 100%? All right. Close. Not close. All right. So I was hoping for 100%, to be honest with you. Okay. I was really hoping for 100% here. Now, if I tell you this is not, this will be tested 100%. Okay. But it will not be as easy as this question. It could be that it's HLA-B 1502 negative, positive, HLAB 1501, 1503, to confuse you. So the first thing you need to know is often detected or positive. And then you need to know that HLAB 1502, it is high yield for Asian population, right? In general, it doesn't have to be Chinese or Korean, or Japanese, Filipinos, South Asian in general, right? They are at risk for developing Steven Johnson syndrome. Now, remember, lamictal and carbamazepine can lead to Steven Johnson syndrome. And if you are ever asked about Steven Johnson syndrome, you need to look at the description of your question. Is the patient in the description Asian? You are talking about they want you to select carbamazepine. If it's not, then lamotrigine is your answer. Okay. So understand again, this is a very important. It is another FDA warning. So we already know 100% that will be on your test. Ask yourself which lab is abnormal here.
TSH.
All right, we got 5
Yeah, I
seconds.
picked too fast.
Yeah, it's all good. Now, I totally get it that sometimes we select answers on Kahoot because the screen is too small. Now, how do we know, like, the first answer? Even if I don't know 15 to 1. Let's think about that for a second. I know Kahoot doesn't give you the time to really think that way, but what is the normal levels of BUN, right? 10 to 20
1020.
happy age. What is the normal ratio for creatinine? The same as lithium,
Lithium.
0.6 to 1.2.
1.2.
So the ratio, it is okay here. It's not concerning. Sodium, or
145.
yeah,
145 is good.
135, you know, so not really out of the range here,
No.
right? How about 8,000 for white blood count?
It's within the
Within range. So only thing that's outside the range is TSH, 0.5 to 5. Now, the Purple Book has a grave mistake. We all make mistakes. I make mistakes all day long, right? But they have a mistake there that says 0.5 to 10. So that is incorrect, okay? Normal, I'm not criticizing, right? I think it's human and it's okay to make mistakes. But TSH lab there, it is a little bit too high. Then if it's too high, is this hypo or hyper thyroidism? Hypo, right? It's counterintuitive, right? Can anybody explain how is it hypo and it is high? Anyone wants to give it a shout out to it?
Low
It's not being
T3 and
used.
T4.
Yes.
It's overcompensating for the
Yeah,
T3, T4.
Yeah, so yes, absolutely. So it's this not inverse, but the shut off loop. right? So when it is in a hyperthyroidism, the body shuts off, so the TSH drop. So that's why we see a low TSH lower than 0.5. When this hypo is over 5. Okay, so it's counterintuitive, but we need to know hypo and hyperthyroidism will be tested 100%. Okay. All right, 5 seconds. All right, so in the previous slide, I mentioned that BUN was 10 to 20, TSH 0.5 to 5, and the white blood count, at 8,000 was normal. What, and I even mentioned what creatinine level was the same as lithium, 0.6 to 1.2. So the only outside the range here again is creatinine. Okay. So if I did not make sense, or if you have a question, always ask. If it was not understood, maybe I mispronounced it, or maybe it wasn't clear the way I mentioned, please ask. Because as you see, we are not really giving you a very hard question, and those questions will be asked. Okay, it will be asked. So we cannot afford, we don't have control over elusive questions like frame. Frame can be very elusive, right? We can study sometimes logotherapy versus existential therapy. It's hard, but these are science that we learn from nursing schools, right? The labs. We got to know our labs, because either it's black and white, or either you know it or you don't. So we cannot afford to miss those easy points, because those are memorization, straight up. Okay, straight up memorization. So we have to spend the time and kind of understand what is really important and what is not, and how it plays a role in psychiatry. And remember, it is not a criticism, but in few weeks, you are in this program, you will pass the board, and then you will be taking care of patients. And it is somebody's daughter's wife, somebody pressures to someone. So we really have to be careful with the power that we have in our hands, so we do no harm. Okay. I can live with any mistake, but knowing that I did harm to someone, it always brings tears to my eyes. I made mistakes before that I start vomiting just to think about it. It wasn't nothing silly, but I start bawling. I don't know why. It's just the thought that I was there to help and that caused some harm. It was not even that a big deal. Really wasn't. I mean, it was the wrong medication, 20 years ago. Same patient, last name, in the same room, taking the same medication. Maybe I was a new med surge, but I know I made a mistake, but that situation wasn't helping either, right? And just thinking about it, it's still, you know, I guess I just finished nursing school and then just I had the meltdown. But we cannot afford to do harm to patients, especially when they're trusting us to do good for them. Okay, we cannot do that at all. So all right, so yeah, so we want to mitigate. It will not take, it will not make it safer to have Depakote, carbamazepine, lithium in pregnancy, but we want to mitigate and help minimize the risk for neurotube defect. Okay, folic acid can give it a little bit of that and helps to some degree, but ultimately we want to transition those patients to lamotrigine as soon as possible. Okay? It's not important that you know the dose either. Just remember folic acid. It is the most abundant and the most excitatory neurotransmitters, both, right? %90 of all neurotransmitters, this one plays a role in withdrawal. It plays a role in seizures, right? Seizures. So glutamate, definitely plays a role in all that. So the most abundant, and then on the other hand, the most inhibitory neurotransmitter, and then it's GABA, right? Serotonin, we talked about all about the Raphael nuclei, mood, sleep, appetite, and dopamine, the rewarding function, executive functions, motivations, help us sometimes feel good as well, help us with depression to some extent. Yes. So the red option, who is responsible for vital functions like heart rate and breathing, brainstem? Yes. Um, regulations of emotions and mood. That's a hard one, but if you think of a system, whose system would be most likely? Yes, both answers, right? If you think of a neurotransmitter, it would be serotonin. But if we think of the limbic system, if we think of the amygdala, then we're looking more of anxiety, fear, um, aggression, right? The hypothalamus, then we're thinking about hunger, thirsty, libido, circadian rhythm. I always swear if you don't get this question on the board, I would be extremely surprised. Circadian rhythm. If you think about the hippocampus, it's all about your memory and stress management. What else? Any other comment in the chat box there? Right? The thalamus, it controls your sensory input so that your brain doesn't get overwhelmed, right? So imagine all the sensories coming in all at once, probably not good. What else? The parietal, sensory perception, where you are in space. Anterior cingulate, you're talking about your impulse control, and sometimes the error inputs is more of anterior cingulate, but impulse control. What else? Any other comments? You guys forgot to ask dorsolateral, orbital, frontal, the occipital, visual portion of your brain, PFC, the prefrontal cortex, part of the executive function, the occipital, the visual inputs, right? The dorsolateral, inattention for ADHD or attention, the basal ganglia, new movement, crash course task 7, I don't know the answer. I don't know what that is. The medulla, fear, anxiety, and aggression, right? So now I'm just kind of talking about the comments that are coming out in the chat box, some of the main functions, right? So now, not only you need to know, and please do not confuse the cerebellum and the cerebrum, right? Now, um, what test would you do to assess balance? It is important.
Rumbeck.
Rumble. Please know that it is important. Okay, it is very important. Okay, so I think we cover all that, the sensory perceptions. Um, what else? We cover all that already. Okay. It's a repeat question of number 1 now, I think. No, it's not.
Yes.
Okay, so pretty much a repeat question from the previous question, right? A little bit more of a fluff into it to give a little bit of flavor, but exactly the same concept, right? So sometimes I like to do that just to see if we just covered a topic, would we be able to apply it, even though the topic was given, right? So we definitely want to make sure we know the rumbar test, okay, how to do examination, right? And don't push your patients too hard because you don't want them to fall either, right? You just want to assess cerebellum. You know, you don't want a patient incident, do you? Perfect. All right. Very good, folks. We need to know our lobes, right? It is a given already. I'm telling you ahead of time, you will be tested. You know, it's not surprise. It's actually such a given that is in the blueprint. So if you want to know what's going to be on the test, look at the blueprint. The ANCC blueprint is they are telling you, oh, any test that you go take, the first thing you should do is actually look at the blueprint because you know what's going to be on the test. You may not know all of it, but you know most, even if you're not, even if you don't have your craft really well at that point. The first thing if I take the GRE, right? I'll go at the test blueprint and I will know somewhat or to some degree what they will be asking, right, ahead of time. Then I focus on those topics. So when we develop our program, we look at the blueprint and I say, okay, if I'm going to ask about the lobes, what is really important? What is really important? Because we don't want to just put a lot of things for you just to make things harder. We want to simplify the process, get to the point, get those important things, knock it out. And then that way we'll accomplish the goal rather than saying, here's 5 books, figure it out. I gave you the content, right? Now we want to break it down, talk about it, repeat it, make mistakes while we're learning until we get it. And this is pretty much what we're doing here, right? We covered the content yesterday and we're repeating, and repeating. And it's totally okay to make mistakes. It's totally fine. I'd much rather that you make the mistake now so that we can identify it's a mistake so that you don't make the mistake on the test date. And that's why we say don't rush the perfection, you know, the process. Is unreasonable to think that in 2 weeks you are going to knock it out what you learn in 2 years. Even 8 weeks is rushing to some extent. If you go to the website, the test center, they recommend you that you study for 6 months. I think that's too much, but we can do this in reasonable 8 weeks with the highest passing rate. Okay. Now, this is a repeat question of the first question with a little bit more fluff. We have never been able to get 100% on this question. All right, 10 seconds. That is the last question of the day, I think, maybe. All right, so we always have this split between serotonin or norepinephrine, serotonin, dopamine. This is a super high yield question. Previously, we talked about someone with depression and anxious, very anxious, you know, the first question. This one was depression, like, and mania. So this is more of a mood, serotonin, and norepinephrine. Now, to be very clear and honest, is far away from being only two neurotransmitters, right? It really is serotonin, norepinephrine, dopamine, GABA, and glutamate in general. And even you can say a little bit more of others as well, right? But unfortunately, the test, I guess fortunately, because what if they give you 7 neurotransmitters and 4 answers to select from? They'll make things even harder, right? So if they are going to ask you for 2 for mood, please remember serotonin and norepinephrine. You will remember this. All right, we got a tough round here. Okay. Yes, this question is in the crash course review because it's an important question. And it is question number 5 out of 161 from module 1. And I repeated in several other questions to make sure that you get it right. Okay, in different formats, but all right. Again, it's a repeat question, right? Slightly modified, but the same concept. Same concept. So it is totally okay, folks. Maybe you're starting today. Maybe, it's not okay if you are at the end of the course and we are making those mistakes from module 1, right? That's a little bit concerning. But if you're starting now, totally okay. Totally okay. But don't worry, we are going to repeat the concept over and over and over and over in different formats until we get it. You cross and pass the board. Well, congratulations, KB. Aniti. And first place, drums, Mungo. All right, 5th place is Oli and hippocampus, probably, right? She is thinking, memory formation, and stress control. Here we go, folks. Wonderful, right? A lot of new people is here today. A lot of new people or students or haven't graduated yet. Maybe they starting the program really early since there is no monthly charge, which is a good thing, I hope. Maybe you are not in the program. So if you feel that this can be helpful, you don't have to be in the program. You can just show up for free every Thursday, unless if we have the crash course review. So this is for the community, is for us to interact, talk to each other, be a little bit less of a strangers, right? And kind of like give a little bit of support. So it has been a great week. We started module 1. Your goal, if you attended Tuesdays and Wednesdays classes this week, complete module 1 questions. Don't let it be Sunday and you're trying to rush to complete it, or not even complete the questions, right? You have to be on top of your game, because what's going to happen is you are going to sleep and you're going to wake up and the board date is going to be soon, right? It will fly by. So if you think about it, this is the most important test of your life. The most important test, as far as, it's not as important as the NCLEX, I would think, because at least you have a license, right? But other than that, it is a very important test, right? So give yourself the time and the preparation that you deserve, because you spent a lot of money and time up to this moment, paying through nursing school, working at late hours, working night shift. Oh, I hate night shift. Anyways, but hey man, hard. Is hard. You can't get the good. Your hypothalamus can't get a good circadian rhythm when you work at nighttime. Is always tired. Don't see the sunlight. Oh man, that's a hard life. Anyways, folks, so this is it for today. So let's call it 1 second here. My computer is kind of freezing on me. 1 second, let me just shut it down. All right, so 1 second, folks. Let me stop recording here. We have to log off. So what I'll do is I'll log off and I'll log right back in, and then can go ahead.
Please.
All right, so this won't be another lecture, I promise you. But if you have a quick question, I'm definitely